different parts of the stomach. The esophagus joins the stomach at the gastroesophageal junction. From there, that point is the cardia, the uppermost part of the stomach, where the esophagus joins the stomach. That point is the cardia, where it is actually a continuation of the lower esophageal sphincter. Then we can see the fundus of the stomach. We should also see, should be also able to identify the greater curvature of the stomach and the lesser curvature of stomach, and between the curvatures lies the body of the stomach. The antrum of the stomach, we can see here the pylorus, where there is pyloric sphincter. So these are the different parts of the stomach. Let us just peel off the layers of the stomach and see what is inside. You can see initially you can see the mucosal folds here with the gastric rugae, and you can see the lesser curvature the folds are less. And we can also see the pylorus, the pyloric antrum, the pyloric canal, and the sphincter. And after the sphincter comes the duodenum. Now coming to the mucosa, coming to the wall of the stomach. After the mucosa, we can see the oblique muscle layers, which is scanty actually overlying the mucosa. Then we have the circular muscle layer. Circular muscle layer is the only continuous layer which is spread throughout the stomach. And we can also see the longitudinal muscle layer outside the circular layer. And after that comes the serosa. Coming to the arterial supply of the stomach. The branches of the arteries which supplies the stomach are the left gastric artery, the right gastric artery, the left gastroepiploic artery, the right gastroepiploic artery, and the short gastric arteries. These are the main branches which supplies the stomach, of which the bulk of it is carried by the left-right gastric artery and the left and right gastroepiploic artery, and the arcade which is formed between the epiploics and the gastric arteries. Now, these are the branches of celiac trunk. These are primarily from the branches of celiac trunk. Let us just see the celiac trunk. The branches of the celiac trunk include the left gastric artery here, the splenic artery, and the common hepatic artery. The common hepatic artery gives off the gastroduodenal artery to become the proper hepatic artery. Now, the right gastric artery can either originate from this is the right gastric artery. You can see the right gastric artery going like this. The right gastric artery can either originate from this hepatic artery, or it can also originate from the gastroduodenal artery. Now, this is the left gastric artery, which is a direct branch of celiac trunk. Sometimes there can be a vessel going from the left gastric artery to the liver. Sometimes tying the left gastric artery near the origin can result in a ischemia of some part of the liver. Next comes the epiploic arteries. The epiploic arteries, you can see the left gastroepiploic artery is a branch of the splenic artery. You can see the splenic artery coming here, and the left gastroepiploic artery is a branch of the splenic artery. The right gastroepiploic artery is generally a branch of the gastroduodenal artery. You can see the right gastroepiploic artery, the branch of the gastroduodenal artery. Now coming to the short gastric arteries. Short gastric arteries only supply some part of the fundus, that is near the fundus. And short gastric artery is a branch of the splenic artery. So stomach is very rich in arterial supply, and so as a result the anastomosis in the stomach are generally good. They will hold on, they can be mobilized a bit, it can be made into a tube for the purpose of esophagus. Even after tying 3 vessels, the stomach can live with 1 vessel. So that is the importance and the richness of the vascular supply of the stomach. Now let us discuss the venous drainage of the stomach. The venous drainage of the stomach is mainly into the portal system. You can see the portal vein here. The portal vein is formed by the superior mesenteric vein and the splenic vein. You can see the inferior mesenteric vein draining into the splenic vein, and the splenic vein and the superior mesenteric vein joins to form the portal vein. The venous drainage of the stomach generally parallels the arterial drainage. You can see here the left gastric vein behind the stomach and the right gastric vein anterior to the stomach. Both the left gastric vein and the right gastric vein drains into the portal vein. Here they drains into the portal vein. Now the next is the right and left gastroepiploic vein. This is the left gastroepiploic vein and this is the right gastroepiploic vein. The left gastroepiploic vein drains into the splenic vein, and the right gastroepiploic vein, you can see here, it drains into the superior mesenteric vein finally. These are some short gastric veins. The short gastric veins also drain into the splenic vein. These short gastric veins are important because here around the fundus there are some esophageal veins which are finally draining into the azygos system, creating a portosystemic shunt here, which is an area of variceal bleed. It's an area of variceal bleed when there is portal hypertension. So as far as that is concerned, the short gastric veins are important. So the left gastric veins, the right gastric veins, the left and right gastroepiploic veins, and the short gastric veins all finally draining into the portal system. Coming to the lymphatic drainage of the stomach, you can see the lymphatic drainage of the stomach is very much important because it is we have to deal with the lymphatic drainage of stomach when we go in for a lymph node dissection in carcinoma stomach. We should know about the lymphatic anatomy therefore. So the lymphatic drainage of the stomach can be divided into different zones of the stomach. So 1, 2, 3 and 4. These are the 4 areas where there is lymphatic drainage. This is the 4th area. Now there are nodes draining each of these points. You can see the suprapyloric nodes drains this part. The subpyloric nodes drains this much part, the area number 2. The superior gastric nodes drains the area number 1, and the pancreatico-lineal or the pancreatico-splenic nodes drains the area number 3. Now what happens is all this drainage, it finally reaches, from all these nodes, it finally reaches the celiac nodes and the para-aortic nodes. So we can see both these nodes together. From all these nodes, it finally drains into the celiac nodes or the para-aortic nodes. So you can see the lymphatic drainage, the suprapyloric group, the infrapyloric or the subpyloric group. You always see the lymphatic drainage also parallels the venous drainage and arterial supply. The suprapyloric group of nodes, they have their drainage based on the right gastric artery, and this area is generally supplied by the left gastric artery, which goes into the superior gastric group of nodes. And the right and left gastroepiploic artery areas goes into the inferior gastric, mainly the right gastroepiploic artery, and this goes into the inferior gastric subpyloric group of nodes, and the short gastric artery and the left gastroepiploic artery goes into the pancreatico-lineal group of nodes. We will see the arteries along with this. So this is the right gastroepiploic artery draining into the subpyloric group of nodes. The left gastroepiploic and the splenic and the short gastric arteries goes into the pancreatico-splenic group of nodes. The left gastric artery, which is the area number 1 as we have shown, this part goes into the superior gastric group of nodes, and the area number 4 as we have shown here, goes into for the suprapyloric nodes. So these are the lymph node supply you should remember. These are the lymphatic groups you should remember, and this is one of very commonly asked questions in the exams, that to draw the lymphatic drainage of the stomach. Coming to the innervation of the stomach. In most of the textbooks, we see this picture, and we will read about the middle nerve of gas, inner cerebellar and anterior and posterior vagus, and these topics. We are mainly, but many a times we stay confused. We are mainly concerned with the vagus nerve and its innervation to the stomach, because most of the acid secretions is regulated by the parasympathetic system and the vagus nerve. Now, you see there are two vagus nerves there, the right vagus and the left vagus, but here it is written anterior vagus and posterior vagus. You see here. So we should remember as posterior vagus is the right vagus and the anterior vagus is the left vagus. We have a code left anterior, right posterior, LARP. A mnemonic is LARP, left anterior, right posterior. This happens due to the rotation of the stomach during the embryonic period. The left vagus becomes anterior and the right vagus goes to the posterior. When we see both these vagus nerve together, it only creates confusion regarding the innervation. Now let us separate the anterior vagus and posterior vagus and see its branches. Coming to the anterior vagus comes down right. The left vagus or the anterior vagus comes down and gives hepatic branches, and after that it continues to the body of the stomach, giving the anterior nerves of Letharge, ending as with gastric branches and crow's foot at the antrum. Now coming to the posterior vagus again comes down from the esophagus. Now gives the celiac branches. After that it gives the criminal nerve of Gracie, and after that it comes the gastric branches and the crow's foot we see. What is the criminal nerve of Gracie? It is one of the first branch of the vagus going towards the fundus of the stomach. What happens is in many a times in case of vagotomy, the criminal nerve of Gracie is missed, and even after the surgery the patient will have recurrence of ulcer. So it is called the criminal nerve of Gracie. So we can say, I will come to it. We are seeing the anterior vagus and the posterior vagus. Now we will here these branches here are also called the posterior nerves of Letharge. The branches of the posterior vagus giving the gastric branches are also called posterior nerve of Letharge. Now we will come to the picture where we put both these two together. Now we will understand this picture. We are seeing the anterior vagus here, its hepatic branch going, and the nerves of Letharge and the crow's foot here. And again we are seeing the posterior vagus going, the celiac branches, the criminal nerve of Gracie going initially, and after that the posterior nerves of Letharge and the crow's foot. Why do you want to learn about vagus? You want to learn about vagus because we want to learn about the vagotomy. Vagotomy is a very important surgery, very important surgery before the advent of proton pump inhibitors. After the advent of proton pump inhibitors, vagotomy has become less popular, but anyway, due to the historical reasons, we will discuss about the vagotomy. There are three types of vagotomy. They are the truncal vagotomy, selective vagotomy, and highly selective vagotomy. You see this horizontal, these rectangles. These are the truncal vagotomy. The right vagus and the left vagus are cut. But when we do like this, the supply to the pylorus, the parasympathetic supply to the pylorus and the sphincter are also gone, and the celiac vessels are also gone, which results in certain functional problems with dyspepsia. Now, in selective vagotomy, what they do is they avoid the trunks, the celiac and the hepatic trunks, and cut below it. Mind you, on all these cases, we have to cut the criminal nerve of Gracie. We have to make sure that it is cut, even though it is highly selective or selective vagotomy, we have to cut the criminal nerve of Gracie. In truncal vagotomy, it is not required because we are cutting it above the criminal nerve of Gracie in the trunks. In highly selective vagotomy, we are only cutting the crow's foot or the final gastric branches in highly selective vagotomy and the crow's foot. You have to cut the criminal nerve of Gracie anyway. So these are the differences between in the highly selective vagotomy, even the branches to the pylorus are also preserved. So that is the difference between truncal vagotomy, selective vagotomy, and highly